Bill. Of course, first of all, I would like to thank the organizers, and specifically Marco, Mariana, our official photograph Andrea, and of course ICRO, not only for the organization, but for his leadership in this fantastic work and leading us to recommendations that I really believe can improve our practice and our patients' outcome. And I would like also to thank my co-workers in the task force, so Shani, Stephanie, and Alizé. It has been a great pleasure to work with you, and I've learned a lot, so thank you very much. And with that, I move to my outlines, and I still have time to quote Birgit, because, well, when we looked into the evidence about PARP inhibitors and radiotherapy in the adjuvant setting in early breast cancer, well, as Birgit said, cut the crap and go to the point. And my point is, it's a data-free zone. So thank you very much. Have a good day. Okay, I wanted to come to Florence together with my co-workers in the task force, so we digged a bit more in the literature. And so we looked into the evidence of combining PARP inhibitors with radiotherapy in a palliative setting, and you will see that the data is mostly regarding brain. And then we looked into the evidence regarding PARP inhibitors and local regional radiotherapy in the situation where the lump is out of the cup, and we will look at that. And to answer Javier's question, we also looked into the combinations that are ongoing, and specifically the combinations of PARP inhibitors, immunotherapy, and radiotherapy. And then we will move on to the statements that we voted. So, regarding palliative situation, well, there is, again, very limited data, but there is this phase 1 trial, which was not meant to be only done in patients with breast cancer. There were 81 patients, but only 25 breast cancer patients, all patients with brain mets. Radiotherapy was 3D radiotherapy, slightly hypofractionated radiotherapy, 30 grays in 10 fraction or 37.5 grays in 15 fractions, together with veliparib. And as Shani said, veliparib is not approved yet, but still, this was a dose, an escalating dose trial, so moving from 10 milligrams to 300 milligrams orally BID veliparib. And the patients were followed, of course, for toxicity with the aim of determining the maximum tolerated dose. And these are the results. The median survival for breast cancer patients was 7.7 months. And if we look into the toxicity, well, you can see that a bit more than 17% of the patients discontinued the treatment due to adverse events. So the tolerance was not so obvious, but most adverse events were probably related to veliparib and not really increased by radiotherapy, as you can see in the different toxicities that were analyzed. So, in conclusion, we can say that at least in this limited trial, there is no unexpected toxicity combining radiotherapy on whole brain with veliparib. And what I thought it was interesting in this paper, well, it's just a model, of course, but they built a kind of predictive nomogram model to have an estimate of what would be the expected survival and what is the observed survival when combining radiotherapy and veliparib. And they saw something that we could consider as a signal. It's very, but it's just a model again. But still, maybe a signal that the combination of radiotherapy and veliparib could improve survival. So maybe it deserves going still in that direction. So now regarding local regional radiotherapy, well, we have this TBCRC 024 trial, which is a single-arm dose escalation phase 1 trial again, limited number of patients again, 30 patients. And those were patients with inflammatory or local regionally recurrent breast cancer. But in case of recurrent breast cancer, these are patients that did not previously receive radiotherapy. Okay, so they only had the radiotherapy within this trial. That's important to keep in mind. And this was normal fractionated radiotherapy, so basic technique, 50 grays, 25 fraction, plus or minus boost, depending on the age. And almost all patients had a bolus. So that's also important to keep in mind in terms of potential toxicity. Huh? And this was combined with veliparib with escalating dose from 50 milligrams to 200 milligrams, so a bit less than what was done in the brain before. And they had the treatment for 6 weeks. And the DLTs were well defined, as you can see, including DLT regarding radiodermatitis. And here are the results. Well, at 1 year, the crude rate of any grade 3 toxicity was 10%, rather limited. But if you look at what happens over time, you see that this rate increases. And at 3 years, we end up with 40% of the patients having a severe fibrosis in the field of radiotherapy. So that's difficult to say that radiotherapy has nothing to do with that. Huh? So maybe we need to keep in mind that we really need long-term monitoring for these toxicities. And that's often an issue with phase 1 trials where the follow-up might be limited. So don't forget the long-term follow-up or relatively long-term follow-up. And another point I found interesting is that the 2 main toxicities were fibrosis, as I mentioned, but also lymphedema. Keep in mind. And now if we are moving from veliparib to olaparib, well, we have the RadioPARP phase 1 trial, again, single-arm dose escalation trial, limited number of patients, 24 patients only. And these were triple-negative breast cancer patients, either with residual disease after neoadjuvant chemotherapy or with unresectable triple-negative breast cancer. And these patients received local regional radiotherapy with 50 grays or 50.4 grays, 3D technique. Some of them had electrons, some of them were fully treated with photons. Among the patients that received 50.4, some of them, those who were below 60 years, received a simultaneous integrated boost in up to 63 grays, and those received the treatment in IMRT, either with VMAT or with tomotherapy. So a mixture of techniques, but again, this points out the importance of having the radiotherapy data to be able to interpret properly the toxicities that we are going or not to see. And this radiotherapy was combined with olaparib, 50 milligrams to 200 milligrams orally BID, again for 6 weeks, and then follow-up, and they looked for the maximum tolerated dose. So at 2 years follow-up, there were no grade 3 treatment toxicity, so quite reassuring data, no cardiac, no pulmonary, no gastroenteritic adverse events. But with a median follow-up of 34 months, there was 1 patient out of 24 that had a grade 2 breast pain, but with fibrosis and breast deformity. So no grade 3 or more, but again, and if we put that in the context of the previous veliparib data, even though it's globally reassuring, maybe it's important to keep on following these patients. And the maximum tolerated dose was not reached. So, very limited data, I'm sorry, but there is hope, because there are ongoing trials, as you can see here on the table that was nicely prepared by Alizé. Thank you very much. We have a phase 2 randomized trial with olaparib that is ongoing with standard fractionation on chest wall and regional lymph nodes. 300 patients are expected, so I guess we will have quite solid data from that. As you can see, there are 2 phase 1 trials also ongoing on local regional irradiation, but all these 3 trials at the moment are recruiting with normofractionated radiotherapy. We do not have moderate hypofractionated nor ultra hypofractionated radiotherapy. So there's a need there. And then, to answer you, Javier, we have the PARP inhibitor immunotherapy and radiotherapy ongoing prospective trials, because indeed, as you mentioned, as Shani mentioned, as Claire mentioned this morning, there is a strong rationale to combine these 3, because PARP inhibitors will increase the release of DNA and activate the STING pathway and potentiate the immune response as well as radiotherapy. So really, analyzing the combination in the clinic of these 3 treatments and how we should combine them in terms of timing, in terms of dose, is really of importance. And you can see here 1, 2, 3, 4 trials that are analyzing that with different PARP inhibitors and in different settings, but settings that are metastatic settings with mostly stereotactic radiotherapy, high doses per fraction, limited number of fractions, and of course, small numbers of patients, but still 4 different trials that will quite soon, for some of them next year, come up with some results. And with that, well, I'm concluding. So there are some reassuring data, but very limited and quite early. I think we need to have this long-term follow-up, I insist again, and I think we do not have enough data today to recommend to use PARP inhibitors concomitantly with radiotherapy. There are ongoing trials, so there is hope to get some data, and of course we need to participate in that trials. And so to finish, I will end up with the statements that we voted. So for PARP inhibitors plus concomitant radiotherapy in adjuvant or neoadjuvant breast cancer setting, we proposed the statement saying that we should, this combination should be investigating in the context of clinical trials or prospective registration cohort. And you see that we agreed with the vast majority on the level of proof 2 and the grade A recommendation. We had the same thing for the metastatic setting. And finally, we, and I insist again, recommend to use this combination within clinical trials. And with that, I would like to thank you all for your attention and this wonderful meeting that I enjoy a lot. Thank you.